at Sunnybrook. Again today, I spoke to the lung disease site group a few months ago, but I gather there was competition for attention that day with another grand round going on. So I'll cover some of the same ground and hopefully some new things. I always like to start my talks by just referencing the fact that smoking is a pleasurable experience. That's why people do it. And if I could get my slides to move, I would advance them. I'm having trouble. So something else. I'm sorry, I got a frozen screen, Lena. I don't know whether you can help me with that. Oh, there we go. So really within about 10 seconds of taking a puff on a cigarette, nicotine reaches the pleasure centers and your brain releases dopamine and you have a pleasurable experience. And that's why people smoke. And that pleasurable experience disappears rather quickly, so you have to smoke again. And so the cycle goes, and it's pretty easy to get addicted. And some of the factors that lead to tobacco addiction are on this slide. Importantly, environmental factors. If your parents smoke, you're likely to smoke. If your peers, when growing up, smoked, you're likely to smoke. And then some personality traits. If you're kind of a young guy, risk-taking, sensation-seeking, you may start smoking. But also, young people who have difficult childhood experiences growing up are often adult smokers. And then there are some interesting genetic factors that determine the age of onset of smoking, the number of cigarette smoking, and just how easy it is to stop smoking once you become addicted, are determined by certain genetic loci that we have. When you try to quit, the withdrawal symptoms peak within a few days and gradually diminishing over a week. And so most relapses occur generally within a week or 8 days. And few people are really able to abstain from cigarette smoking when they don't have help to quit. It's really down in the single digits. And people who do try to stop smoking make many, many attempts. We used to say maybe 6 or more. Recent studies suggested maybe 30 or more attempts to quit, and before they're finally successful. And of course, if you were successful in quitting, you may relapse when there's a stressful event in your life. And of course, what's more stressful than receiving a diagnosis of cancer? Now, we know that tobacco smoke contains almost 70 carcinogens, a whole lot of other harmful substances to people's health. We know that the largest percentage of lung cancer is caused by smoking. And in addition, there's at least a dozen other cancers, mostly in the aerodigestive tract, so from your mouth down through your stomach and pancreas, but also cancers of the cervix, kidney, bladder, bowel, and even acute myeloid leukemia. Smoking is a factor in the induction of these malignancies as well. And overall, smoking is probably responsible for about 30% of all the cancer deaths. Now, the Surgeon General's report in 2014 reviewed over 500,000 patients and 400 studies and came to the conclusion that if you continue to smoke after a diagnosis of cancer, it increased all-cause mortality, meaning death from any cause, cancer-specific mortality, as well as the risk of second primaries. And there was suggestive evidence as well that it increased the risk of recurrence, that you had a less good response to treatment, and it increased treatment-related toxicity. In fact, the U.S. Surgeon General's report suggested that quitting at the time of a cancer diagnosis might reduce the risk of dying by 30 to 40%. And that's caused some of us to say smoking cessation is really the fourth cancer treatment, because the benefits of cessation rival some of the benefits of our best treatments. Now, just to review the different modalities we use in cancer treatment and see what the impacts of smoking are. As it relates to surgery, the 30-day mortality after a surgical operation is much higher in current smokers, and they're more likely to have to go back to the operating room for a second operation. They're more likely to have complications from their general anesthetic, and they're certainly more likely to have post-operative lung infections and problems with their wound healing, both in terms of infections in the wound, but also because of the way nicotine affects blood vasculature, compromises blood flow to the wound, It impairs the inflammatory response and impairs the ability to lay down fibroblasts and collagen, so you can have late development hernias or wound dehiscences. As far as radiation therapy is concerned, we know that radiation works best when the blood oxygen level is normal. And when you smoke, tissue oxygen levels are lower, which reduces the chance of a complete response to treatment and may decrease overall survival and progression-free survival. And a very interesting Canadian study, the lead author was George Broman, evaluating the effects of radiation on head and neck cancer. They found the complete response rate for those who were smoking during radiation treatment was much lower, 45%, than for non-smokers at 74%, and a remarkable difference in 2-year survival, 39% for those who smoke versus 66% for the non-smokers. And the toxicity of radiation is consistently greater amongst those who continue to smoke. And those results have been confirmed by the Radiation Therapy Oncology group in the US in a couple of trials of oropharyngeal cancer. And they also identified that the risk of disease progression and death increased both on the amount smoked and the duration of smoking. And just to show the benefits of quitting, even at the time of starting radiotherapy, look at the right-hand panel here, and you see that you have the long-term people who had stopped smoking. At the bottom curve, those who continue to smoke. And then there's this intermediate curve of recent quitters. So people who quit at the time of the diagnosis or the start of radiotherapy had a superior survival to those who continue to smoke, showing that it really does make a difference to try and help our patients stop smoking if they're starting on radiotherapy. I wish we knew more about the effects of smoking on all the various drugs we use. We've had so many drugs today, and only a few have really been evaluated for the effects of smoking and how it might perturb their metabolism within the body. But on the left-hand side of this table, you see some commonly used chemotherapy drugs and molecular targeted drugs. And most of these are metabolized by the cytochrome P450 enzymes in the liver. There's a whole lot of subtypes of those enzymes, as you can see by the letters and numbers. But ultimately, they can be disturbed, or those enzymes can be induced by cigarette smoke, and hence the metabolism of these drugs can be faster, or the drug clearance from the body can be faster. And we have some good examples of that, particularly for the tyrosine kinase inhibitors, erlotinib and sunitinib. In the case of erlotinib, there's a much lower response rate in lung cancer patients who smoke, and would actually take twice the dose of that we usually use of erlotinib to achieve blood levels that were effective. There's studies that show survival shorter in those with kidney cancer who smoke taking sunitinib. And irinotecan used in a number of situations, including colon cancer. The serum levels are much lower in those people who smoke, and we can see less neutropenia as well. That's the rapid clearance isn't the only mechanism by which our cytotoxic agents may be interfered with. Smoking induces some acute phase reactants in the blood, and these can bind to drugs like the taxanes, Taxol, docetaxel, and make them less effective. But we need to do an awful lot more research to understand the impact of smoking on our various systemic therapy agents. And in particular, with regard to the immune system, because tobacco smoke really has a whole lot of different impacts, as you can see on this particular slide, activating the immune inflammatory response, upgrading or upregulating T cell function, decreasing natural killer cell cytotoxicity, downregulating B cell activity. So there's a whole bunch of ups and downs. It's really quite confusing in many respects. But there have been a couple of systematic reviews and a meta-analysis done on the effects of smoking and the immune response. And early on, there were observations that individuals who were current smokers had a higher response rate, particularly if they had a high mutational burden. And the meta-analysis done by Day and published in eClinical Medicine in 2021 really concluded from 28 articles of all these trials, almost 14,000 patients, that the immune checkpoint inhibitors we use are significantly prolong the overall survival more in those who smoke than chemotherapy compared to patients who were never smokers. And in addition, when you combine chemotherapy and the immune checkpoint inhibitors, you get a better overall response in both smokers and never smokers. But the benefits of dual immune checkpoint inhibitors and other combinations of ICIs is prolonged survival only in smokers and not in never smokers. So it kind of the reverse of what we might like to have heard. Perhaps we'd like to think that smoking consistently had a negative effect on all our systemic therapies and other therapies, but in the case of immunotherapy, it's different. And maybe we have to actually think about, if the patient really can't quit, refuses to quit, maybe we have to actually adjust our choice of therapies as a consequence. Now, there have been some systematic reviews and meta-analysis as a result of all the publications in a variety of different tumor types now. And a lot of the work has come out of this particular unit in Florence, Italy. It's the Cancer Risk Factors and Lifestyle Epidemiology unit in their Institute for Cancer Research, and they're published under Dr. Kaney's. And the first was a lung cancer a meta-analysis based on 21 articles, 10,000 lung cancer patients, in which they demonstrated that quitting at or around the time of diagnosis resulted in a 30% lower risk of death. And then subsequently, they did a study in 2022, head and neck cancer, published in the British Journal of Cancer. 10 studies were evaluated for survival, 2,300 head and neck cancer patients with a 20% lower risk of death. And then they looked at GI malignancies, much less material here, 6 studies in colorectal and just single studies in gastric and liver cancer, but suggestive evidence that patients who quit have longer survival. And in the case of bladder cancer, only 3 studies and with conflicting evidence. But then there's this report from Mandy Sheik at the IARC. They worked with the urological department in research center in Moscow. And there were over 200 patients with renal cell cancer, 40% of whom quit smoking at the time of diagnosis. And with a follow-up of over 8 years, they showed that compared to quitting, continued smoking, or I should say it the other way, compared to continued smoking, quitting led to almost a 50% decrease in the risk of overall death, 46% decreased risk of cancer death, and a 56% decreased risk of disease progression. And you can see on the survival curve on the right, quite a remarkable difference between those who quit at the time of diagnosis and those who continued smoking. And that seemed to apply to all stages of kidney cancer, as you can see here, perhaps most dramatic in stages 2 and 3, but even in stages 1 and stage 4, you get this quite dramatic separation of the curves in those who were successful in quitting versus those who were not. And then this I found quite interesting from a different group. It was a meta-analysis of hormone-dependent cancers, so 5 studies of breast cancer, 3 studies of ovarian cancer, 1 of endometrial cancer, and 3 of prostate cancer. And for all the tumor types except prostate cancer, smoking cessation led to better overall survival, disease-specific survival, disease-free survival. And so, again, strong arguments for helping our patients stop smoking, no matter what the cell type, with few exceptions. So why is that even happening? What are the potential mechanisms? Well, it may be that part of the benefit is that you reduce the risk of other causes of death from smoking, heart attacks, respiratory failure, infections, and so on. So avoiding those comorbidities or avoiding treatment-related complications. I've already spoken a little bit about altered drug metabolism. And also there are changes in the immune system that we don't fully understand. But there may also be changes in the cancer cell biology. And it's interesting that nicotine works through the N-acetylcholine receptor, a particular subtype of it, the alpha-7. And that particular pathway stimulates a number of signaling pathways within cells that oncologists are familiar with. On the right, the RAS-RAF pathway that leads to proliferation, the PIK3 pathway, and mTOR pathway, which affects survival, invasion, etc. So it may well be that the nicotine is actually changing the cancer biology. And this is a very busy slide from Graham Warren of all the possible interconnections between nicotine and the signaling pathways that can alter apoptosis or cell death, proliferation, cell migration, angiogenesis, and so on. In vitro, you can actually demonstrate this. This is an example of human lung cancer cells treated with nicotine. The control on the left, the nicotine-treated cells on the right, and you see in the lower parts at 12 and 24 hours, there's increase in migration and invasion of the cells into the culture medium. And it affects apoptosis. It really inhibits apoptosis by agents like gemcitabine, cisplatin, and Taxol. So you see the controls on the left with nicotine alone, and then you see the effect on apoptosis of the chemotherapy, and then how it's muted with the combination of nicotine and chemotherapy, get less apoptosis occurring. So there's a good biological rationale for quitting, and there's clear evidence from meta-analysis now of the important impact of continued smoking after a cancer diagnosis, resulting in worse survival, which gives us a very good reason to try and help our patients to stop smoking. So it starts with asking, because cancer diagnosis really is a teachable moment. People may be more motivated then to quit smoking than previously. But when we talk to them, we have to be empathetic, recognizing this is a powerful addiction. We have to use simple language to educate them about why quitting or reducing smoking is important, and how there are these immediate benefits to their cancer treatment if they quit. And what are the options available to them at the Sunnybrook Cancer Center to help them quit? Now, we do have to have some flexibility. We would ideally think that asking them the first visit would be a good idea, and that probably works most of the time. But there'll be some people who are just overwhelmed with the amount of information provided about their cancer diagnosis, the subsequent treatments, and you really have to be sensitive to when is the best time to have that conversation. We have to recognize that they've probably already tried to quit many times, and so they may be thinking that it's not possible, but we need to provide them with the resources to make it possible. It is interesting to look at this data from PMH that patients really expect to hear about smoking cessation during their first visit, and 3/4 of the patients think that that's when the discussion should occur. And almost 90% felt that smoking status should be assessed by an oncologist rather than other members of the healthcare team. Now, I can't see the room, so I don't know how many oncologists are present. From past experience, I find it's usually not too many of them. But it's so important that the oncologist, in a few words, support the importance of smoking cessation at the time of that initial consult and on subsequent visits to the cancer center. Patients expect to hear from their oncologist. If the oncologist doesn't say anything about smoking cessation, and maybe the nurse introduces the topic, maybe they won't take it as seriously. But the oncologist really just needs to endorse what the other healthcare providers are telling the patient about the health benefits of cessation. And there is a readiness on the part of cancer patients to quit smoking. This is perhaps a little surprising because lung cancer patients and head and neck cancer patients shown on this slide are generally the most heavily addicted. And yet, in this series again from Princess Margaret, 60% of new lung cancer patients were very interested in making a quit attempt in the next month, and others were somewhat interested. And even more dramatic in the head and neck cancer patients, where 86% were interested in quitting. So patients are receptive. And we need to know that and be comfortable and confident that we can talk to them about it. So how are you doing at Toronto Central North? Well, in terms of screening, you're doing better than the provincial average, generally speaking, over the last few quarters. Unfortunately, you're not doing that well in terms of accepting a referral. And there are probably many factors involved in this. I know you've gone through a big change in your information systems, transitioning to Epic. It's a big cancer center. It's hard to get all those things done, but there are probably a variety of different barriers that you're trying to overcome. Some of it may be a lack of knowledge of the health benefits of cessation. I can only hope that this talk helps to add to your knowledge and understanding of those health benefits and convicts you that it really is worth talking to cancer patients about this. You may feel a lack of skills in communicating with people who use tobacco. You've never used tobacco yourself. You can't understand why anyone would become addicted to smoking. Don't they understand the harms that can happen? You may have some particular prejudices against smokers. It's not uncommon. But we have to have empathy for these individuals. They probably started young, became addicted, and just have not been able to break the addiction. And we need to try and provide them with the resources to help them. And that's a problem too. We haven't really made it abundantly available, all the resources that could be helpful. We don't provide or haven't provided free NRT or other pharmacotherapy. We don't have enough people to do all the counseling that would be really ideal to support people who are trying to quit. And of course, the cancer centers are dedicated to treating cancer, and they're tremendously busy, particularly in a post-COVID time. So there's a lack of time to actually include smoking cessation into the discussions you're having with your patients. And of course, many think it's just not their job to do, and that includes the oncologist. This is a survey done by the National Cancer Institute in the United States, and I think it's relevant to Canada as well. Who do the oncologists think should do it? Well, in the green, it's about any other clinical staff but me. And it may be primary care, it might be other physicians, nurses. Only 1% would prefer to treat the cancer patients themselves. And I think that's probably reflective of most oncologists in the Ontario system. So what can we do? Well, in your center, you've introduced a rapid access addiction medicine clinic, which you're going to hear about, I think, from Darby. You potentially could participate in the STOP implementation that is rolling out in the province. Quite a few centers are doing that now and are gaining access to free NRT. You could utilize Health 811 as the quit line service that's now available, in the province. You could implement intensive smoking cessation counseling to the extent possible. We know that the combination of pharmacotherapy and counseling over about a 12-week period is what would breed the most success. And you could implement a tobacco use survey to assess tobacco use following treatment, find out whether people are continuing to smoke, and to use those follow-up visits as an opportunity to reintroduce conversations about smoking cessation and making referrals. And ultimately, if we had all the centers across the province capturing smoking status using the tobacco use survey, we would be able to undertake studies ourselves to show what the benefits are of cessation by tumor type and stage, and perhaps generate more information that would compel us to feel we really should be doing this routinely across the board in all of our centers with all of our cancer patients. This final slide, as was mentioned in Alima's introduction, I've chaired the Tobacco Control Smoking Cessation Committee for the International Association for Study of Lung Cancer, and we've introduced this position statement on smoking, which we've shared with other organizations globally. That first of all patients with cancer should be screened for tobacco use and advised on the benefits of tobacco cessation. Secondly, that patients who continue to smoke after diagnosis of cancer should be routinely involved in, or should routinely have tobacco cessation assistance integrated into their multidisciplinary cancer care, and including their family members. That educational programs about cancer management should include tobacco cessation training, empathetic communication about tobacco use and cessation, and how to use the best evidence-based tobacco cessation resources. And we should be capturing smoking status both initially and during clinical trials that we do, so we can learn more about the impacts of continued smoking versus cessation on all these new drugs that we're evaluating, and drugs in combination with radiotherapy and immunotherapy. And we really should be considering the clinical trial designs that we build so that we can actually learn more about how smoking cessation works. The final thing to just leave you to look at is that in 2022, Meredith Giuliani, Lawson Ng, and myself were guest editors for an issue of Current Oncology. There's about 13 articles on various aspects of smoking cessation included in that special issue, including the impacts on cancer surgery, effects on radiotherapy, systemic therapy, including immune checkpoint inhibitors, and the setting of non-small cell lung cancer. But there are many other articles that you may well find of interest and value as you try your best to help your patients to quit smoking in order to get the best outcomes from their cancer therapy. And I'm just after 12:30, so at that I will stop, Alima, and if I don't know whether you want to take any questions now or leave them to after Darby has a chance to speak.
Sure. Why don't we take some questions right now? We do have a few oncologists on here as well. So thank you so much, Dr. Evans. If anyone wants to raise their hand to ask some questions, or feel free to type them in the chat box. Any questions or comments for Dr. Evans?
Oh, Bill, it's always a pleasure to hear you speak. Bill is very modest. I just wanted everyone to know that he was recently given the Joseph Cullen Prevention and Early Detection Award from the International Association for the Study of Lung Cancer at the World Lung Cancer Meeting in Singapore. That's a great achievement, Bill. Congratulations.
Well, thank you for bringing that up.
A question for you, Bill. As you know, the province is about to roll out CT screening to many of the thoracic centers. So where do you see the impact, or where does smoking cessation fit in, especially for screen-detected lung cancers?
A very good question, and thank you for bringing up the low-dose CT screening work. We actually, when we piloted the low-dose CT screening in the province, we integrated smoking cessation into the screening program, and I think it's well recognized that a low-dose CT screening program has to have smoking cessation sort of built into it. The program was actually interesting because the 3 pilot sites were each allowed to do what they could do within the limitations of the resources. One center used the Ottawa model of smoking cessation, which is the most intensive of the 3 approaches that were used in the province. And frankly, it was the most successful. And of those who were current smokers going into the low-dose CT screening, at 1 year, they had a 20% smoking abstinence rate. The other centers had much less support available to them. They tried to refer people back to their family physicians for smoking cessation, to pharmacists, group counseling sessions, but only a limited number of them. And those were less successful. The one center had a cessation rate at 1 year of just 10%. The average for the whole province was 15%, which may seem low, but in fact, to be abstinent for 30 days, 1 year out from a smoking cessation program is actually quite good. And what we are encouraging is that as each new center comes on board with low-dose CT screening, is that they be screened for smoking status by the navigator, and that they be referred to an on-site smoking cessation service in the hospital, ideally the same day that they're there for their low-dose CT scan, and that they receive follow-up subsequently. We recognize that the resources vary across the province, what centers have available to them to support people who are trying to quit. And we'd have to keep advocating for more resources to make it possible to be most helpful, because it's a combination of pharmacotherapy and motivational interviewing and counseling that's most successful in helping individuals. And then when patients come back for their annual CT scan, it's another opportunity to determine their status. If they're still smoking, then we go again to try and help them to stop, and hopefully we'll progressively enable more and more who are on those screening programs who maybe continue to smoke to help them to stop smoking. So that's a not so brief summary of what was in the pilot, and that's recently been published in the Journal of Thoracic Oncology, actually at the first of this month. So you can read about the smoking cessation efforts during the pilot low-dose CT screening program.
Thank you. Any other questions? And congratulations, Dr. Evans, on your award.
Thank you.
I'm not seeing any other hands raised or anything in the chat box. So maybe we'll go to you, Darby, and then after that, if there's any additional questions, we'll have some time to do that. So thanks so much, Dr. Evans. And next we have Darby Erler. Darby is the professional lead for radiation therapy program at the Sunnybrook Odette Cancer Center. She is appointed as an instructor with the Department of Radiation Oncology, University of Toronto, and a practice-based researcher at the Sunnybrook Research Institute. Darby completed her degree in radiation sciences through the Joint Michener Institute, University of Toronto Medical Radiation Science Program in 2003, and received a Master of Health Science and Medical Radiation Sciences from the University of Toronto in 2015. She's been a regional co-lead for smoking cessation since 2019, and her research interests include evaluating innovations in radiation treatment delivery, enhancing the integration of MRI into radiation therapy, and improving the patient experience with the use of patient-reported outcomes. Thank you so much for joining us, Darby, and when you're ready, please take it away.
Thank you, Lima, and I'm going to assume you can see my screen. Excellent.
Yes, thank you.
So thank you for the invitation. As Lima mentioned, I have been the co-lead for smoking cessation at Sunnybrook for the last 4 years. This is going to be my last official duty in that role, as I'm leaving smoking cessation in Alima's capable hands, but I will continue on as the champion for radiation therapy. So, and thank you to Dr. Evans for setting the stage about how important this is for our patients. So I'm really just going to talk about, just to remind everyone, what the services are that we now offer at Odette, and just a little bit about our general program. So, okay, there we go. So when we think about smoking cessation, you know, when Alima and I do attend the meetings with the other regional cancer programs, we just think about the complexity of how big our program is and how many intakes. And this is even a very simplified map. But a lot of our other, you know, the other programs do have their own, it's a single way in, and they have a person that asks these questions immediately when the patient is referred. And we know that's not necessarily feasible for us because there's so many different ways that patients do enter our system. So when we took a look through the pandemic at how to improve our program, we kind of mapped out the different touch points. And again, as I said, it's very simplified. But just to give you an overall sense of sort of how the patient flows through the system and where there is opportunities for smoking cessation. So there is that registration, seemed like a very natural place. And for a while we did try a paper-based screening process. But with the advent of all the virtual care, and then with Rest Center in a separate location, this proved not to be as successful as we wanted. Having said that, though, the registration and consult is a very, very important part of the process, particularly when the physicians see them. And we do also will acknowledge, as Dr. Evans said, the oncologist plays such a vital role. And we do know from sort of chart audits that we did, smoking status is usually ascertained as part of the history and physical in almost all patients. Whether the advise happens, not entirely sure always, but definitely the conversation is started there. I guess one of the limitations currently with our program is that data is collected in Mosaic, and not every physician would have access to Mosaic nor the time to document there. So we know the ask is happening, probably close to 100% of the time the data isn't necessarily being collected. If we build on from that new patient referral and they have their consultation with the physician, then normally a nurse will follow up to do a new patient assessment. So this is one of the areas that we have concentrated on, that the smoking cessation data is captured in the nursing new patient assessment, is one of the areas that they will also address with the patient, hopefully building on conversations that already started with the oncologist. Then as the patient moves through, we also know if a patient's coming in virtually through a peripheral clinic, nurses don't always get to see them. They may not get to do their virtual assessment, but hopefully things within the system are changing. We have what we call the catch-all. So that's the other allied health professions also playing a role. So whether it's the radiation therapist that planning on treatment, nursing when they see them through radiation treatment, or the chemotherapy nurses, or pharmacy when they're doing some of their proactive calls. So we all can play a role to build on the start of these conversations, just to follow up to make sure that the patients do have the supports that they require. And then we have put very intentionally on this map, transition to survivorship. And this is certainly an area for future expansion that we haven't even expanded into, but something to explore for the future. So Dr. Evans also mentioned a bit about our data. I'm going to talk about it, but there's we'll move on to the next slide. So we do, under the guidance of CCO Ontario Health, we do follow what we call as the Smoking Cessation 3A model. And that's really just to ask, advise, and act. So the goal is to ask all new ambulatory patients about their current or recent, and that's within 6 months, smoking or tobacco use. The recent, because as Dr. Evans alluded to, former smokers can relapse. So it's important to be aware that they may be struggling also with recently quitting, to see if they need to be supported further. Advised is, again, all the wonderful data that was just presented us, how important and what a difference it can make to the patient's cancer journey if they do stop smoking. And we've just noted on this slide the benefits of quitting smoking pamphlet, and I'll speak to that in the next slide. It is some resources that Ontario Health does provide. And then the ACT, and that's really the referral options, and I'll speak about those in more detail. So Ontario Health, as I said in the advise, has produced some resources, and these can be found in all the clinics. So the pamphlet you see on the right discusses, it's an easy, quick resource of what are the benefits to patients if you quit smoking. So even if in the first conversation you just identify they're not really ready, this resource may be helpful for them to start pondering the benefits and help get closer to making that decision to wanting to quit. The pamphlet on the left is also, they have developed e-modules on their website that also go through to help encourage patients to quit. So both things are available in clinics for any clinician to hand to patients, just to help further reinforce the benefits of quitting. And in terms of the ACT, as I said, we now have 2 standard referral options, which has been a challenge within the program for the last few years, particularly through the pandemic. So the first, and what we would consider our preferred referral option, is the Sunnybrook RAM, which is the Rapid Access Addiction Medicine Clinic. So RAM actually started partnering with us at the beginning of the pandemic, and their original idea was to offer virtual support groups. But it was very challenging to get traction and enough referrals to that, and to assemble enough people for the group setting actually to function. So I believe they only ended up doing 1 of those virtual support groups. But the main social worker in charge, Rachel, has, persevered and has evolved based on what patients have expressed that they wanted. So they will now do 5 to 10 or less. I would say sometimes that may seem like a high number for patients of individual counseling sessions with the social worker. And within those counseling sessions, they will teach you the skills of motivation and how to set goals, and it's different strategies to manage cravings or triggers. And there's some psychoeducation also provided. But probably most importantly is that the patients do have access to nicotine replacement therapy through this clinic. And there is a physician that works there that can help prescribe and manage that. So very simple to refer. There are referral forms in all the clinics, or you can email or call directly, and any healthcare provider can make this referral if a patient is interested. We've also, to try and understand more, we're working to collect more data from RAM now, so we know how many referrals have been made, how many patients are successful and such, because some of the other provincially led interventions, we've never been able to have that information. So this is what we call our internal referral, and then external. And this is probably the referral option that's caused the most confusion for anybody. It was Smokers Helpline way back, and then when Ontario Health was formed, it became Telehealth Ontario, only to be transitioned to Health Connect Ontario, but has now landed on Health 811. So this still, it's the provincially offered smoking cessation support. Patients are paired with a quick coach, and then they're offered free face-to-face counseling or group support. Also will have access to nicotine replacement therapy. The referral forms are also available in clinic and within the pamphlets. The challenge with this is that we have found we've had patients referred there. There's quite a wait list to get contacted by a quick coach. And also when the quick coach calls, it's from a blocked number and they don't necessarily leave a message. So making that initial contact sometimes isn't as easy. And these are a few of the reasons why we are encouraging the RAM referral if possible. Again, I'll say anybody can make this referral. So whether it's a nurse, a radiation therapist, a pharmacist, anybody can for both options. So a couple of other things that we've done. So, and kudos to Alima, especially for the patient-facing website. There was a lot of outdated information. So no, we've now, everything is it's in line with what our options are. So this is for what the patients see from our website. So there's now information on Health 811 and the RAM clinic, as well as CCOs, their print material, but they've also developed that online e-learning module for patients, so they can access that through ours. Internally for healthcare providers, we've also tried to update to get an easy one-stop shop place to find any of the fillable referral forms, the current pamphlets, and as well, Ontario Health has created a learning module for healthcare providers, just if you want to learn more about supporting patients who want to quit smoking. So a little deeper dive into our data. So as Dr. Evans said, in terms of the ask, yeah, I would say we're doing well. We're at the provincial average. We're not necessarily at the target now. We've slipped a little just for a few changes in process. But we believe we're probably closer to the 100%. It's just a product of maybe the data not being collected in Mosaic because not necessarily every provider interacts with it. But certainly in the screening, we've always performed quite well. For the advised, again, also really in line with provincial averages for the most part. We also believe we could be a bit higher, but we're doing well. And then, yes, where the challenge has been is in referrals. Sort of anecdotally, we know from speaking to the different leads of our health professions, there's always been so much confusion, particularly around when, all the evolution to Ontario 811, because nobody knew which form was the right form. What are we doing? And then as well, just RAM wasn't particularly attractive as a virtual only option. but I think now we've landed on 2 good, stable referral options. So we are really quite optimistic that this is going to be improved in the future. So just really in conclusion, there is an absolute clear benefit for cancer patients to quit smoking, in which Dr. Evans did a wonderful job of well, we didn't need convincing, but illustrating that for us. So we do, as a program, we now have 2 clear established referral options: the internal to the Sunnybrook Rapid Access Addiction Medicine Clinic, or external to Health 811 Smoking Cessation. And really, as a program, we do anticipate improvements in indicator performance with changes to the referral options, or clarity, I should say, process improvements in transit, and once eventually when we transition to the new HIS, there may be a better way to extract data. I will say, though, as a committee, supporting the patients is our absolute #1 priority, not necessarily the data. And I think we do a much better job than what the data tells. But we are also expecting that the data is going to start to improve as well. So with that, we do have additional resources which we can share at the end, and I would be happy to answer any questions as well.
Thank you so much, Darby. Any questions, please feel free to type them or raise your hand or just unmute.
Thank you, Darby, for that excellent presentation.